It's my great honor to be here to join all of you for this ELSA webinar on advances in surgical endoscopy. Therefore, my task today is to give a short presentations on the treatment for achalasia, and then title it is From Surgery to Nooks. This is the outline of today. My talk. We talk about the diagnosis and the current treatment options for achalasia. We will talk about briefly the techniques and the results of a poem. And we also update the audience, the recent pivotal randomized studies in this field of poem compared to other treatment modality. And finally, we end with some recent advances. As many of you know that achalasia is a swallowing disorder characterized by the failure of a relaxation of our lower esophageal sphincter, the LES, together with an absence or abnormal esophageal body peristalsis. And the patient will experience symptoms such as dysphagia, regurgitation, chest pain, and weight loss. And these symptoms are very distressing and significantly affect the patient's quality of life. The diagnosis for achalasia is usually started with endoscopy because to exclude organic obstructions. And for patients with achalasia, you will characterize by a dilated esophageal lumen with fluid retentions, but no mucosal diseases. And on barium swallow, you will see a characterized stricture at the lower end of the esophagus, which is regular compared to the irregular strictures for malignant diseases. And of course, nowadays, we make a diagnosis of achalasia by a high-resolution manometry, which is demonstrate the two cardinal features of achalasia, namely the absence of body peristalsis and elevated LES pressure. And with HRM, we actually can subclassify achalasia into type 1, type 2, and type 3. This is the treatment options. Conventionally, the two standard treatment option for achalasia is balloon dilatations and surgical myotomy. But certainly in the last decades, most attentions are into what we call peroral endoscopic myotomy, or we call POEM. The balloon dilatation have been around for many years. It's the most common procedure for achalasia, and usually is performed with endoscopy and thoracoscopic guidance. The advantage of balloon dilatation is this is a very simple procedure, relatively, and minimal invasive. However, the disadvantage of balloon dilatation is usually you require many type of occasion, multiple treatments, and the treatment itself is actually blinded, and there's a risk of perforation, which increase with subsequent repeated balloon dilatation. And surgical myotomy is the gold standard for treatment for achalasia. And this first started by Professor Heller, who first described the surgical myotomy for achalasia in the 1914. So this procedure has been around more than 100 years. And of course, nowadays, excuse me. Of course, nowadays we perform a laparoscopic way. And laparoscopic Heller myotomy is a standard. And as you can see from the video, this procedure actually is very nice to perform laparoscopically or robotically. And because you can see the G junction very clearly below the liver and at the hiatus. And the procedure usually is performed together with a fundoplication. And but nowadays, in the last 12 years, many people will are interested in this new technique called POEM, which is a lateral orifice surgery, because we perform actually a surgical procedure through our oral orifice. And the procedure is based on the concept of submucosal tunneling in the esophagus, and pioneered by Professor Inoue 12 years ago, when he performed started the series of POEM in Japan. And therefore, through his vigorous academic research and trainings, and this procedure really become very popular procedures around the world. The concept of POEM is based on this theory of what we call a submucosal space or submucosal endoscopy. This cartoon showed this concept that this is the a wall of the GI tract. On the top is the mucosa, and it's surrounded by the bottom is by the muscle layer. And when you create a space in the submucosa, once you create a submucosal space, in fact, then you can perform any procedure, any surgery at the muscle layer. And once you close the mucosal defects, because of this mucosal flap, and they will have no full thickness perforation. And this is what we call a concept of a submucosal endoscopy. Techniques of POEM is essentially 4 major steps. First step is mucosal entry. The second step is submucosal tunneling inside the submucosal space, and you tunnel all the way to the gastric cardia. And then the third step is to perform the myotomy within the submucosal space. And once the myotomy completed, then you close the mucosal wound with mechanical clips. Just show you an example of a case of POEM for a case of sigmoid achalasia. This is one of our earliest early series, just performed to show that POEM can perform for cases of sigmoid achalasia as well. You can see that the esophagus was well tortuous with a tight GJ. The first step is a mucosal entry. Therefore, we lift up the mucosa with saline, with indigo carmine, and then we using an endoscopic knife, we'll make a 2 centimeters incision on the mucosa. Then we'll insert our endoscope into the submucosal space and to create this submucosal tunnel. Here we are in the submucosal space. The one on the 3 o'clock is the muscle layer. The mucosa will be somewhere in the 9 o'clock positions. And you dissect the space close to the muscle layer to avoid any thermal injury to the mucosal layer. And you will encounter some blood vessel within the submucosal space. You can either divide it through the knife or with a coagulation forceps. We confirm that the submucosal space that we reach the cardia by this double endoscopy techniques that show that we have already created a tunnel all the way to the cardia. And once that you've done that, then you perform a myotomy and with endoscopic knives. Actually, very similar to what we perform laparoscopically or robotically. We can actually see the individual muscle layer, but this one is from the endoscopic view. And many of us will perform inner circular myotomy and try to leave the outer layer intact to prevent inadvertent injury to the mediastinum. And you can see that this one, you see that the end of the myotomy, along the entire lower esophagus to up all the way to the gastric cardia. And finally, back to the esophageal lumen, then you close the mucosal defect with clips. And this is the end of the thing. This slide will summarize the advantages of a POEM from the AGA practice update. Basically, POEM provide the advantage, including there's no skin incision for our patients. The patient didn't require any abdominal surgery. They will avoid any potential problem of adhesions or nerve injury. The patient won't, because there's no fundoplication, they don't have any fundoplications issue, such as gas bloating. And POEM is actually a surgical myotomy. It's actually a myotomy, therefore it's a definitive treatment for achalasia. And you can apply to a patient even with a previous intervention because you are entering into a different surgical plane. And also for sigmoid esophagus. And more importantly, this procedure can also extend the myotomy proximally to as long as you to the proximal esophagus. So it's a great treatment for patients with spastic achalasia or proximal esophageal motility disorder such as the DES or jackhammer esophagus. This is our experience since 2014. We have performed about 73 cases of POEM so far. And the pathology, you can see that there are a variety of, mainly for achalasia, mainly type 2, and some of them are type 3. And we also apply it for others, less common esophageal motility disorder. Duration of symptoms varies from a week to 30 years. And 1/3 of the patients have previous treatment before, such as balloon or Botox or even surgical myectomy. We have about 7 patients have sigmoid esophagus. The average procedure time is about 129 minutes, and median hospital stay is about 3.6 days. This is our perioperative complication related to it. We have no conversion, no modality, and no cases of leakage from the mucosal wound and the intestinitis. But we do have some cases of pneumoperitoneum, which is treated by needle decompressions, surgical emphysema, 1 case of myocardial infarction after the operations, and 1 case of a pseudoachalasia. This is very important. Even though we do all the cases have done endoscopy and endoscopy and high resolution manometries and even CT scans, and we have to really exclude cases of pseudoachalasia, especially for older age patients. We have the most common complication we encounter is mucosal ischemia near the GE junction, and usually it is the tight area, tight space, but all the cases are managed conservatively. This is our result of our POEM in terms of efficacy. We measured it by the symptom, by the composite score called ERGAT score. The ERGAT score is a composite score composed of the dysphagia, regurgitations, and weight loss and chest pain. Therefore, you can see that from this graph that the preoperative ERGAT score in median is 6. We decreased in 1 year to 1. Therefore, our treatment success as defined as ERGAT score less than 3 in 1 year is the 91% in our series. This is a very recent summary of the results in the literatures. Summarize all the prospective series. As you can see, that the series are ranging from 32 patients to 233 patients. To highlight here is that I can see the efficacy rate is usually from 83 to 100%. Adverse event is also relatively uncommon, from 2% to 40%, depending on how you define as adverse events. Recently, there's 2 pivotal randomized studies have been published. The first one is a randomized study compare POEM versus pneumatic dilatation, balloon dilatation, where this study is a multi-center study from Europe and also Hong Kong. They randomized 130 patients newly diagnosed achalasia into either POEM or balloon dilatations. The primary outcome of this study is efficacy at 2 years. As you can see, that POEM have the efficacy is 92%, which is significantly better than pneumatic dilation at 54%. In terms of adverse events, both procedures are relatively safe. There's 1 perforations, but there's 1 perforation for pneumatic dilatations. You can see that this is a serious complications. And there's also 1 mucosal tear in POEM. And, but in terms of reflux esophagitis, the study also showed that POEM have a higher risk of reflux esophagitis. Most of them are LA grade A. I think these studies, Philip is one of the principal investigators for these studies. And this study showed that POEM is more effective compared to pneumatic dilatations. Next study is also a very recent study comparing endoscopic POEM versus surgical myectomy. And this is a study randomized 221 patients, 112 on POEM, and then 109 patients for laparoscopic hair myectomy with fundoplication, which is a gold standard treatment for achalasia. And this study design is a non-inferiority design because POEM is a less invasive procedure. As you can see that the primary outcome, you can see that this study is positive because it showed that both POEM and halar myotomy have the same efficacy and no difference in terms of efficacy. But in terms of adverse events, POEM is less compared to surgical myotomy. But again, this study also showed that POEM is associated with more risk, or higher risk of POEM compared to surgical myotomy. There was this landmark study showed that the POEM is as effective as halar myotomy, but with less adverse events. Certainly, one of the main drive of this procedure is patients, because most patients prefer endoscopic treatment compared to a surgical procedure. And this is reflected in our practice in our own hospital. Therefore, you can see that this procedure for achalasia performed in our 10 years, in our last few years in our department. Usually, we perform about 2 to 3 laparoscopic halar myotomy per year. But over the year, you can see the trend for surgical myotomy decreased, but the rate for patients who are choosing POEM significantly increased, more than tenfold. It's very rewarding to treat this patient with achalasia, regardless what either surgical or medical or endoscopic myotomy, because these patients really suffer a lot by not eating. As an example from this newspaper articles, is one of our older patients, and the patients finally can enjoy a decent meal after 30 years of achalasia. Some of the recent advances, as we mentioned, that one of the issue of a POEM is reflux. Therefore, Professor Inoue has developed this procedure for POEM plus F, or plus fundoplications. And I think maybe Philip will talk a bit more about this procedure. As far as I know, I think the procedure are still evolving. And but this is certainly some good news for people that have a complication of reflux. And certainly the field of surgical submucosal endoscopy also expanded to other diseases, such as gastric POEM for gastroparesis, or ZEC POEM for patients with Sanka diverticulum. And submucosal endoscopy can apply for patients for excision of submucosal tumor. We call it a POET, or a STIR, submucosal tunneling endoscopic resection, where I think Philip will talk about it in his lecture. Let's just show you a quick video on a recent case of gastric POEM, what we call per-oral myotomy for patients with gastroparesis. Therefore, gastroparesis, the problem, we're using a similar techniques like POEM, but the target is in the pyloric muscle. Therefore, first we enter the submucosal space about 2 centimeters near the pylorus, and we lift up the mucosa with saline injection. Then we make a horizontal incisions. I'm sorry for the video. I don't know why, probably because of the transmissions. I apologize for that. But basically, we make a transverse incisions at the mucosa, just large enough for our endoscope. Large enough for our endoscope, and then we enlarge. Then we enlarge the space with further saline injections. Then our endoscope can enter into submucosal space. Then we dissect the submucosal, create a submucosal tunnel, and we dissect the space until you see this pyloric muscle, which is on this 12 o'clock positions. Then we dissect it a little bit beyond the pylorus. And this is the true lumen. They can look at to confirm the location of pylorus. Then once you then after that we did a myotomy like the usual way using the endoscopic knife. So this procedure has been getting popular in the last few years around the world, and the result is also very encouraging. And once we finish the myotomy, I can see this is the last layer of the pyloric muscle. Beyond that is the serosa. And this is at the end of the myotomy. And then we close the defects, the usual fraction with the endoscopic clips. Therefore, in summaries, ladies and gentlemen, POEM has evolved now to be a definitive treatment for achalasia, and now have actually level 1 robust evidence which confirmed that the POEM is effective and is also a safe treatment for achalasia. And POEM is especially indicated for patients with spastic achalasia and esophageal spasm, and also can apply for patients with recurrent achalasia with previous treatment, and also for patients with sigmoid esophagus. And certainly the field of POEM or submucosal endoscopy is evolving and is now applying to other diseases along the GI tract. With this, thank you so much for your attention, and I welcome any comments and questions.
Thank you.